So thank you so much for listening to me before the networking session. So I'm from the Board of Governors of the Federal Reserve, so the usual disclaimer applies, and nothing of what I will show you today represents the views of the board, my colleagues, or the reserve system as a whole. So I'm going to start by giving you a sort of a motivation that is really at the heart of the project here, and that's the fact that shouldn't surprise you at all that fee-for-service really matters. And fee-for-service payments are a particular payment scheme in the United States where physicians are paid according to what they do and not according to who they are. So to give you a better idea of this, say that I'm a primary care physician and I'm gonna carry out an EKG. I'm gonna be paid for that EKG just as much as a cardiologist will be paid. So it's not dependent on my specialty, it's only dependent on what I do. Now, in terms of how important they are, well, they make up for about half a physician's income in the US, so it's very important. And historically, specialty procedures have always been more remunerative than primary care procedures, and that shouldn't surprise you. However, what should surprise you is that the gap between typical specialty procedures and typical primary care procedures has been widening over time. So in other words, carrying out a specialty procedure has become increasingly more remunerative. And that's independent of, that's also true for procedures that, for example, have become more efficient, less time consuming, or less technical over time, okay? So because of what I just told you, since it does not matter who I am, but it only matters what I do, this generates a clear financial incentive for primary care physicians to substitute to these more remunerative specialized procedures as soon as they can. And there's many margins you could consider. What I focus on in my paper is the urbanity margin, or in other words, how urban or how rural an area is. Now, why does that matter? Well, it matters because specialists are highly concentrated in cities. So when you go more and more rural in the US, you have fewer specialists around, and primary care physicians have more of that leeway of saying, you know what, I will refer you to a specialist because I can just carry out the procedure myself. And it's easier for you to do that because if you live in a city, well, if you want to get an EKG, most likely you'll even just want to go to a cardiologist because for you it's so easy and just across the corner or whatever, right? So this is basically the mechanism that comes into play. So what do I do in this paper? What am I trying to answer? Well, I want to understand how basically increases in these policy set reimbursement rates, that's why I focus on Medicare, as they're policy set and exogenous, lead to primary care physicians carrying out more procedures themselves rather than referring the patient. And in particular, I'm gonna focus on are rural primary care physicians able to do so more the more rural the area, rather than basically compared to the primary care physicians in cities because of the lower level of competition that they face, okay? So of course, I don't have much time today, and I'm gonna show you just one graph before jumping into the results. So all my data comes from CMS, and the only thing I wanna tell you before showing you the graph is what I consider a specialty procedure. And to do so, I just basically entirely on the data, I look at the entire universe of physicians and procedures, and I look at the frequency with which each procedure is carried out by each type of physician. And that frequency basically becomes the level of specialization. So in other words, if a procedure is carried out by specialists 70% of the time, that procedure is specialized, okay? So this is a graph that I wanna show you to give you an idea. So what you see here is on the x-axis for both graphs, you see the urbanity index. The higher the number, the more rural the area. So as you move left to right, this becomes more rural. On the left graph, I show you the percentage of physicians of either type that carry out at least one of these specialized procedures. And what are specialized procedures in this case? I'm focusing on very specialized procedures that are carried out by specialists 70 to 80% of the time. So they're very specialized. Now, on the right, I show you the percentage of all these specialized procedures that are carried out by either type. So this is a mouthful. What does that mean? This means that if you look at the cities, which is Urbanity Index 1, you see that about 45% of primary care physicians carry out at least one of these specialized procedures. But taken all together, they carry out about 20% of all of these specialized procedures. When you go very rural, you have the 80% of primary care physicians carry out at least one, and taken all together, they carry out more than 2/3 of all specialized procedures in rural areas. So in other words, what is this showing you? Primary care physicians carry out a lot of specialty procedures as they go more rural. So let me jump on a couple of things. I'm going to show you a very quick reduced form result. And this is the first thing, what I want you to get away from this is, do primary care physicians respond to these increases in reimbursements generally? And here what you see is a procedure becomes more remunerative. It's a unit change that's equivalent to about $36. And what I show you in the two columns, the first column says, is a primary care physician going to increase the number of times that she carries out the suddenly more remunerative procedure? And that probability is a 17%. Now, if you give higher weight to those that already carry out that procedure, then that probability jumps to almost 50%. Why does that matter? Well, imagine again the EKG, most likely there's some fixed costs that I'm actually not incorporating here at all. If you already have the machine and you're already carrying them out, well, this suddenly becomes more remunerative. That's fantastic, more money in my wallet, right? So there's a higher probability with which you'll do it. Now, this is very reduced form. There's a very big structural results, structural model in the background that I don't have time to talk to you today, but I want to just show you these basically red box results right here. So what am I showing you here? Because there's a lot of stuff going on. So it's always with a reimbursement change of 1 unit, which is equivalent again to $36. Imagine again the EKG becomes $36 more remunerative. And all of these stages, all of these results are relative to the primary care physicians that are in the most urban place, which means large cities, okay? And this is the increase in market share that they managed to get in that suddenly more remunerative procedure relative to their most urban counterparts at the expense of specialists. What does that mean? Let's walk through it. Let's take the example of rural at 12.3%. Let's say that the EKG becomes this $36 more expensive, more remunerative. Then the primary care physicians in rural areas have a gain in their market share in EKGs 12.3% higher than the primary care physicians in cities at the expense of the specialists within the same health market. So if you take the procedures, normally they will split them in a certain way, specialists to primary care physicians. So you see that as it becomes more remunerative, primary care physicians take it away out of the market share of the specialists. Now I'm going to conclude with a very sort of, one more thing. Here, if you see, is that small metropolitan areas and very rural areas are the most affected, but all of the less urban areas show that their ability is higher, and the results are very robust. All the other numbers that you see are just different specifications of the model. I'm going to conclude with one very low, sort of subtle result that is sort of important though. Here, what I showed you today is also the primary care physicians respond to this by increasing their market share within the same health market by taking it away from another specialty. Why does this matter besides being interesting on its own? Well, there's a large literature talking about, for example, overutilization. But the issue with this is that often when we look at the overutilization, you focus on groups, for example, of physicians. Now, take the same example that I gave you now. Well, if we were looking only at primary care physicians and we were looking at the EKG rate, as the EKG becomes more remunerative, you will say, oh my God, overutilization is going up like crazy, because suddenly you see all these primary care physicians doing EKGs. But you wouldn't capture the fact that it's not just a pie getting bigger. Part of the pie is actually just a reallocation across the specialties that are carrying out the same procedure. So it's important because it also sort of sheds light on the fact that there's it's sort of two sides of the same coin as we make a procedure more remunerative.